inflammation, when there is slight edema, slight change in color, and when there is no bleeding on propping. I want one of you tell me about the normal color of gingiva. And when there is slight change, what the color will be. One of them, I want one of them to answer. What's the normal color of gingiva? Please.
Is it pink?
Yes.
Pink?
I think it is light pink, the normal.
Pink, coral pink. Okay. Anyone else can give me the normal color of gingiva? It is pink. But when there is slight change, it means it goes toward redness. Why redness? What do you think? Why redness?
More blood vessels.
دور التهاب باللثة.
Yes. Gingival inflammation.
Increased blood flow?
Because more blood will go to the area as a defense mechanism. So, number one means mild inflammation, slight edema, slight change in color, but no bleeding on propping. When you move a probe in the sulcus, there is no bleeding. Remember that. Now, number two. Number two means moderate inflammation. What's the meaning of moderate inflammation? Means that there is redness. It is not just slight change in color. The color will be red. There's redness, edema, and glazing. It means shiny surface of gingiva because it becomes spongy, full of blood, red color. And there is bleeding on propping. There is bleeding on propping. Number three means severe inflammation. Severe inflammation, there is marked redness, it's very clear, that's red, and edema, ulceration, and spontaneous bleeding. What's the meaning of spontaneous bleeding? Maybe when he answered our question, his gingiva bleed during talking or when touched by his tongue. It means spontaneously, sometimes without any excitation, there is bleeding on the gingiva. This means severe inflammation. And during your practical work, you will see that very clearly. It is for those with very bad oral hygiene, they never brush their teeth, or sometimes due to some systemic diseases. So, when we move the probe gently in the gingival sulcus, there is 4 criteria to assess the gingival condition. 0 for normal gingiva, 1 for mild inflammation, 2 for moderate inflammation, and 3 for severe inflammation. It's easy. The scoring, it's the same like we mentioned in the previous lecture for plug index. Now we score 4 gingival surfaces. 4 gingival surfaces. Mesial, distal, facial, lingual per area. For the tooth, again score for each area totaled by 4. We have 4 number per tooth. This number, we total it and divide it by 4. So for each tooth, now we have 1 number. And for a group of teeth, score and summation of these numbers per tooth divided by number of the teeth examined. Okay? And for the individual, for example, I want to know if I have mild, moderate, or severe gingivitis. So for individual, totaling the scores, all scores of all teeth and dividing by number of teeth. For each tooth in my mouth, I have 1 number, either 0, 1, 2, 3, So we totaled this number and divided by the number of teeth examined. The gingival index will determine total score for individual is total score divided by number of surface examined. Do you understand this point? Is it okay? Shall we go to the next slide? Okay. The rating. So if we have gingival index, we have 0, means no inflammation, so it is excellent situation. If the score range between 0.1 to 0.9, it means good. If from 1 to 1.9, it means fair, متوسط. If the score range from 2 to 3, it's poor, very poor. You have to know these numbers. It's very important. It's just like plaque index. And again, it's by low and stillness. Shall we move to another index, or you have a question? If you have any question, please ask. Do you have any question? Any questions?
Dr.
Yes.
I didn't get the difference between the groups and the individual, like GI for like groups and individuals. Could you please repeat that?
Here, the slide.
Yes.
Okay. Group of teeth, not group of individual. Group of teeth. For example, if I have 20 teeth, but you examine only 10 of them for me, so the score should be divided by 10. But it doesn't mean that my score is that number. If I want to know my score, you have to examine all teeth in my mouth and divide by the number of teeth examined. But if we want to know, for example, 10 of them, the score of 10 of them, 9 of them, it is a group of teeth. في كل الأحوال تجمع وتقسم على الرقم الموجود، على رقم الأسنان. Okay?
Okay, Doctor, I got it. Thank you.
Okay, thank you for you. Now we will go to community periodontal index of treatment need. This one have two parts. It is an index, gives the situation and gives the treatment need. CPITN, Community Periodontal Index Treatment Need. It's very widely used in surveys everywhere. A joint international dental federation, FDI, and also WHO working groups was established in 1979 to develop this one for a survey. They assess the periodontal condition, okay, and give the treatment need through the same survey. The Community Periodontal Index of Treatment Needs is a quick system, quick one. Provide the information most necessary by simple examination procedure. How? Now I will explain it more for you. You have to know the name, CPITN, Community Periodontal Index of Treatment Need, suggested by FDI and WHO for a survey, Survey meaning examination of a community, of a population, of a group of people at the same time, in certain time, in the same location at certain time. This index provides a rapid and reproducible method of assessing condition from one visit. Okay, the World health organization probe. We use a special type of probe called WHO probe. WHO probe. And use first by WHO technical report. The design of that probe is designed for gentle manipulation. It's very gentle and have no sharp end. Gentle manipulation of sensitive soft tissues around the teeth. This probe, WHO probe, has two special characteristics. First, it has ball-ended tip of 0.5 millimeter diameter. The end of the probe is not sharp, it's a ball. The diameter of that ball, it's very small, about half centimeter. It means 0.5 millimeter. Less than 1 millimeter. It's 0.5 millimeter. So first characteristic of this probe is that it has a ball-ended tip of 0.5 millimeter diameter. Second characteristic, the graduations are a band of 2 millimeter, which is color-coded. 2 millimeter color-coded. Shaft beginnings 3.5 millimeter from the tip. Okay. Further modification of the probe incorporate into 8.5 millimeter, 11.5 millimeter. The rationale for ball end, why the end is ball? For detection of subgingival calculus, and secondly, it's less likely to excessive pressure and cause penetration to the tissue. The force for the probe is between 15 to 25 grams. We can't weight it, but it is come by experience, a very gentle probing. This slide contains a lot of information, but it is easy. How? We use WHO probe for the CPITN. WHO probe have two characteristics. First, it is ball-ended, and second, the graduation have color. How? You can see in this figure. Yes? Just imagine this one. This one is ball end, and this is color code. Color code. If the reading is still this point, it means the depth of the sulcus is 3.5 millimeter. If it entered to the gingiva, so till this area, it will be 5.5. 5.5. Then will be 3 millimeter, 3 millimeter. Starting with 2, then 3, 3. It is color-coded, very easy to read the depth of the sulcus. It will be more clear when you have practical work. See the end, the ball end. Here it's very clear. 0.5 millimeter diameter ball end. Then from here to here is 3.5 millimeter. This one 2 millimeter, so become 5.5. This one 3 millimeter become 8.5. This one 3 millimeter become 11.5. This is about the probe that you use in CPITN, Community Periodontal Index of a Treatment Need. Okay? Probing procedure. A tooth is a probe to determine pocket depth. Pocket depth detects calculus and bleeding. So, during probing, During examination, we can determine pocket depth, we can detect if there is calculus and bleeding response for sure. Do you know what is pocket? Anyone have idea what we mean by pocket? Jabe, what's that one in the teeth and gingiva? Anyone have information? What is pocket? We have gingival sulcus, you know? Yeah, we have gingival sulcus. Normally it is gingival sulcus, but if there is deepening due to inflammation, the deepening will call pocket because there is food debris, plaque, calculus, so there is dew, pocket. Normally it is gingival sulcus, but any deepening in the sulcus we will call it pocket. Understand?
Yes, doctor.
Yes. Probing force is divided into working component to determine pocket depth. Working component. When we want to know the depth of pocket, we will enter the probe inside the sulcus, parallel to the long axis of the tooth. For sure, parallel to the long axis of the tooth. This means working component. It works to see if there is pocket and to measure or determine the pocket depth. Second one is sensing component. Sensing. If it moves very smoothly, it means it's okay. But if there is catching, it means we have to sense or to feel it. It is sensing component. That means that there is calculus inside that pocket. We can't see by our naked eye, but we can feel it. Okay? And if there is overhang restoration, the restoration not come end to end. It is overhang. Overhang. We can again feel it by the probe. Use of standard force in probing is not more than 25 gram. Since this amount of force is resisted by healthy epithelial attachment and sufficient to elicit bleeding from the area. According to research, they see that 25 gram pressure, it means very, very light pressure, it's enough to see if there is bleeding, to see if there is calculus, to feel or to measure the gingival pocket. When inserting the probe into periodontal pocket, the ball point should follow anatomic configuration of the root for sensing subgingival calculus. It means we have to know first the anatomy of the tooth. Incisor is different from canine, and canine is different from premolars. Premolars again differ from posterior teeth. You have to know the anatomy when there is prominence, if there's depression, so the probe will follow this anatomy. And then you can feel, you can sense any subgingival calculus. Is that clear? Group A, Group B, Group C. Is that clear?
Yes, doctor.
One more?
Yes, doctor.
Okay, you are 3 groups. So, the probe is inserted, again, it's very explanation, between the tooth and gingiva. We insert the tooth between the tooth and gingiva. The sulcus depth or pocket depth is sensed and read against the color code. You remember we have color code, and according to the insertion we read the millimeters. The ball end should be kept in contact with the root surface. The ball end kept contact with the root surface. Pain to the patient during probing is indication of heavy force or heavy pressure. the patient feel discomfort during probing. But if he feel pain, it means that the pressure is more than the required one. Okay, now how we assess the index. The index is used to detect the presence or absence of what? As we mentioned, of bleeding, of calculus, of pockets. Bleeding, calculus, and pocket. The index teeth in the epidemiological survey for adult age 20 years and more, index teeth are examined. What are index teeth? Do you know? What are the index teeth? For each index, we have index teeth. For each index, we have index teeth. Do you remember for oral hygiene index, we examine molars, first molars, and central incisor? Yes, that's right. Now, the examination include central and both molars for upper, left central and both molars for lower. It means 5 in the upper and 5 in the lower. You know the nomination or the numbering of the teeth? 17, 16, 11. It means 7 means second molar, 6 first molar, 11 it means central incisor for the left side, for the right side, 6 for the left side and 7 for the left side. And for the lower jaw is the same examination except the central for the upper in the right side will be the central in the left side because we start with 1, 2, 3, 4. 1, 2, 3, 4. We divide the mouth into 4 parts. The one will be for each tooth, but the number of tooth will be 7, 6 central. For the part 2, for the left, number 2, 6 and 7 only. For lower, left, 7, 6 central. For the lower right, 6 and 7 only. So we have 5 teeth per jaw. For the upper jaw, there is 5 teeth, and for the lower, there is 5 teeth. Centrals and 6 and 7. 6 and 7 everywhere in the right, left, lower, upper. 6 and 7, it means first and second molars should be examined. And central incisor for upper right and lower left. So we have 5 index teeth per jaw. The molars are examined in pairs and the highest score is recorded. It means if we examine, for example, we have 4 surfaces to examine, the number 1, 0, 2, 3, for example, the highest score recorded, not all the scores, only the highest score. Only 1 score is recorded for each sextant. For young people below 20 years, only 6 index teeth. It means just central and 6s because we are not going to examine second molars, just first molar, incisor and first molars. This is for those below 20 years. But those above 20 years, we examined first and second molars with centrals. And why is that is happen? Because the second molars may give false pocket false pocket. What's that mean? Because during eruption, the gingiva may be inflamed and there is a wide space. Sometimes we make a mistake or make false diagnosis. We put it as pocket, but actually it's not pocket. The tooth is in eruption time. That's why below 20 years, we exclude the second molars. And for screening and monitoring purposes, in adult over 19 years and above, highest score of any tooth in the sextant is recorded, ignoring the lower scores. In examination of children less than 15 years, pockets are not recorded, although probing for bleeding and calculus is carried out in the same procedure. Because during the time of eruption, there is some change in the gingiva may give false diagnosis. The important here is that you have to know, below 20 years, there are 6 index teeth examined, molars and 2 central. Above 20 years old, 10 index teeth will examined, and in all cases, only the worst score will be recorded. The worst one, يعني not the good one, the worst one should be recorded. So no need to summation and divide it. It is just think about, and the worst one will be recorded. The examination procedure, the main aim is to determine the highest score for each sextant with minimal number of measurements. The requirement is that more than one functional tooth should be present. More than one functional tooth should be present. The tip of the probe is gently inserted between tooth and gingiva. As we explained before, the tip of the probe is gently inserted between the tooth and gingiva to the full depth of the sulcus or pocket. Recommended sites for probing are mesial, midline, and distal on both facial and lingual side. The probing may be done by withdrawing the probe between each probing, or alternatively with the probe tip remain in the sulcus. The probe is walked around the tooth. This one, I think it will be more clear in practicing, during practicing, if there is patient and you stand in front of him. The probe insert into the gingival sulcus to the end of the point, okay? And we can move it without withdraw the probe. We can measure 3 readings from mesial and 3 readings for distal. Why 3 readings? We have mesial, midline, distal for facial. We have mesial, midline, distal. Lecture?
Yes, doctor. So should to put the probe between the tooth and the gingiva and
Okay.
the measurement the depth.
Okay. I'm measuring the depth. How many sites you measure? 6.
We measure facial, both facial and lingual, palatal surface.
Facial and lingual. For facial, 3 readings. For palatal, 3 readings. Why?
For the what?
For the facial, 3 readings. Mesial, midline, distal. For the lingual, the same. So we have 6 reading per tooth. Okay?
Yes, doctor.
Okay. I think it's easy. Just think about inserting the probe and examine 6 points per tooth. 3 facial and 3 palatal or lingual. Without withdrawing the probe, just walking or moving the probe in each side and write down the number, the measurement. It's easy. Now, codes and criterion. The appropriate code for each sextant is determined by code 4. What's meaning of code 4? Pathological pocket of 6 millimeter or more. Wow, it's too much. It's too much. So code 4 means pocket of 6 millimeter or more. Colored band of CPITN probe is not visible, because if it is visible, it means that it is 5. It's not visible, so it is 6. If the designated tooth are found to have 6 millimeter or deep pocket in sextant examined, and code 4 is given to the sextant, there is no need to record the presence or absence of pathological pocket 4 or 5 millimeter, calculus or bleeding, because code 4 means very severe and it is above 6 millimeter. So code 4 means pathological pocket of 6 millimeter or more. That's it. Code 3, it's pathological pocket of 4 to 5 millimeter. It means part of the color band is visible. Okay? That's it. No need to say that there is calculus or not. You have pocket from 4 to 5. Code 2, the whole color band is visible, but supragingival and subgingival calculus retentive factors are fitting crowns. So code 2 means that it is not deep pocket, but there is subgingival and supragingival calculus is there. Code 1 means bleeding. Code 1 means there is bleeding on probing. Without calculus, without any deep pocket. Code 1 means only we have bleeding. And code 0, as usual, it is healthy. Code X, when only one tooth or no teeth are present in the sextant. Okay? But usually we start from 0 to 4. So 0 means healthy tissue. 1 means bleeding present. 2, it means supra and subgingival calculus. 3 means pathological pocket of 4 to 5 millimeter, and 4 means pathological pocket of 6 millimeter or more. That is it. Now, treatment needs, because you know this index divided into 2 parts. Diagnose the case, assessing the case if there is bleeding, if there is calculus, and if there is pocket. Community periodontal index give 3 variables: bleeding, calculus, and pocket. The second part is that treatment need. So what treatment we need? Assess only the condition potentially responsive to the treatment. It does not analyze non-treatable or irreversible condition like recession or attachment level. It just gives the condition and treatment for that condition. It didn't take in consideration any recession, or recession mean lowering the gingiva, apical migration of gingiva. The term treatment need is intended as guide to the level of care need. It provides as indication. Yes.
Can you repeat the code 2 for the person?
Yes. This one?
Yes.
Code 2 mean there is supragingival or subgingival calculus. That's it. This is what you have to know. Because this index give 3 diagnoses, either bleeding or calculus or pocket. Bleeding, when there is bleeding, there is code 1. When the number 2 means supra or subgingival calculus. 3 pocket 4 to 5 and 4 pocket from 6 millimeter and more. Okay, so code 2, it means supragingival or subgingival calculus. That's it.
Okay.
Okay.
Excuse me, doctor.
Mm-hmm.
Can you repeat the slide before the code 2?
Or code 4? Starting
Yes,
with
no.
no.
And the codes and yes.
Yes, this one.
Yes,
So
this slide.
code 4.
Yes.
Code 4. Pathological pocket 6 millimeter or more. This is very severe condition. Means that the tooth is mobile. 6 millimeter or more means that gingiva detached from the tooth. This is code 4. That's it. Code 3, there is pocket, but from 4 to 5. This one is enough for you. Okay?
Okay, doctor.
Okay. Okay. Now we classify the treatment needs according to the code number. Treatment need for code number 0, TN0, means no need for treatment. Yes? No need, because it's healthy. Treatment need for number 1. Do you remember number 1? We said that only there is bleeding on probing. So, when there is bleeding, what do you prefer? Personal hygiene. Please brush your teeth. Control your teeth. Give appointment to the doctor to help him, to the dentist. So, when treatment need for the bleeding is just improving personal oral hygiene. Try to correct your method of brushing or brush your teeth more than 2 times a day. Treatment need for code 2. Code 2, do you remember what's code 2? We have calculus, supra and sub. Supragingival calculus or subgingival calculus. It means the treatment will be scaling. What is scaling? It's removing the calculus. Professional scaling using Cavitron or by instruments, by scaler or curate. When we know what number 2 means, so the treatment will be very easy. Number 2 means there is calculus. So professional scaling and removing plaque retentive factor should be done. Okay? Treatment need for number 3. What's number 3? I think it is, there is pathological pocket between 4 to 5 millimeter in depth. So the treatment for that type of pocket will be complex treatment. Not only one treatment, complex, by scaling, deep scaling, root planning, deep scaling and root planning. Okay? And because the pocket is the same, there is detachment between the gingiva and the tooth. So treatment need for code 4 is very complex. What's that mean? It may need surgery, maybe need bone graft, may need extraction and prosthetic. It is complex procedure. Okay. So if code 0, you can repeat, please. Anyone can repeat the treatment needs for each code number?
Doctor, this for code 0 is not treatment because it is health issue.
Okay.
For code 1,
What's the meaning of code 1?
code 1 is just bleeding. So
Bleeding,
we should
yes.
advance the patient to
Okay.
personal hygiene.
Good. And what meaning of code 2?
Code 2, we have the supracalculus and
Or supra or subgingival calculus.
Yes, we have both some that we to use the scaling that.
Yes, professional scaling by dentist.
Travis, I have a question. We should use the instrument or with the chair? That instrument with the chair.
With, excuse me?
We have two instruments. Sometimes we use that instrument, the sonic.
Yes, or ultrasonic.
Yes, doctor. We should use both or something.
No, you know, it depends according to your experience. Sometimes there is only one calculus in specific area, one calculus, one area. For example, what's the area of collection of calculus? Do you have any idea? In which area the calculus will be more? Even if you examine your family, where?
Gingiva?
In near the gingiva, where? In which teeth more?
Sometimes it's posterior.
For example, upper 6, buccal surface of upper 6. And usually in the lower anterior teeth lingual side. These areas are difficult to brush. Lingual surface of lower anterior teeth. Most of persons have calculus in the lower lingual surface of lower anterior teeth. So professional scaling will be by using Cavitron ultrasonic. If you have just a piece of calculus, for example, in upper 6, you can use hand scaler. But nowadays, I think no more use for hand scalers. All dentists use Cavitron in their clinic. The Cavitron should be used very carefully because it is electrical vibration and may be harmful for the tooth surface. May lead to losing of the soft or bright surface and make ditching. It's very complicated. The Cavitron should be put on the surface, below the surface or the base of the calculus. Avoid touching the tooth. Avoid touching the tooth. And if you put the Cavitron below in the base of the calculus, direct it toward the gingiva, not toward the teeth. Toward the gingiva, it's no problem. It may be used, it may lead to removing of the calculus and again killing microorganism by electricity, electrical vibration. I think the time is over. We reached the end of the CPITN. And that's it for me for today. You have only 15 minutes lecture. Thank you for you all. Thank you for you. Have a good day. And I hope the success for all of you. Bye-bye.
Thank you, Doctor.
Thank you for you. Bye-bye.